Good evening and welcome to tonight's masterclass, where we will be discussing knee osteoarthritis treatments, and in particular, hyaluronic acid injections for OA pain relief. My name is Peter Shaw, and I am the Chief Medical Officer at Bioventus, and I will be your moderator for tonight's class. We have an excellent faculty with us to discuss the topic in hand, weighing your options for hyaluronic acid and why molecular weight really matters. This is a particularly timely subject given the updated 2021 AAOS guidelines, where statistically significant improvements were associated with high molecular cross-linked hyaluronic acid versus mid-range hyaluronic acid. There isn't a one-size-fits-all treatment protocol for knee osteoarthritis. Today, we will place hyaluronic acid therapy within the context of knee osteoarthritis treatment journey and highlight the value and scientific data of high molecular weight HA. I'm really pleased to introduce our faculty, starting with Dr. Vin Dasa. He's an orthopedic surgeon at Louisiana State University Health School of Medicine in New Orleans. He's professor of clinical orthopedics, director of research, and vice chair of academic affairs at LSHSC. He's also the co-founder and chief medical officer at Site Medical and the co-founder of the novel medical education platform, DocSocial. Also joining us is Dr. Jack Burt, an orthopedic surgeon at Woodbury Bone and Joint Specialists in Minnesota, and adjunct clinical professor emeritus at the University of Minnesota School of Medicine. Dr. Burt previously held the position of president of the Arthroscopy Association of North America, or AANA. Before we start, there are a few housekeeping points. We're so glad that you joined us tonight and want you to be part of this discussion. If you have a question at any time during the masterclass, please click on the Q&A button at the bottom of your screen and type in your questions. We welcome your active participation. Starting us off will be Dr. Dasa, who will talk to you about the past, present, and future of hyaluronic acid, how to manage it, and what are your options in its treatment. He will set the stage for Dr. Bird, who will speak specifically to Durolane, a high molecular weight hyaluronic acid option backed by clinical data and favorable outcomes. Over to you, Dr. Dasa.
Thanks, Peter, for introducing our talk today on knee arthritis and hyaluronic acid. We're going to cover a lot of ground today, so please pay attention. Here are my disclosures for the regulatory purposes. So osteoarthritis in the knee is drastically changing. We're seeing a dramatic growth in the number of patients in the younger age demographics that are achieving total knee replacement and seeing advanced arthritis. We can see how that spike is increasing over time. If you look at the orange graph here, typically 45 to 64 years old, you're seeing a tremendous growth in the younger population compared to the 65 and over. And I remember when I was a resident and I was a medical student, doing a knee replacement in someone who was 70, it was very commonplace. But if someone did a knee replacement in someone who was 50, there was almost a food fight during conference where surgeons were screaming at each other saying, how can you be doing a knee replacement in someone so young? But fast forward to today, doing a knee replacement in someone who's 50 or 55 years old is extremely common and almost normal. So we can see that the face of osteoarthritis is changing. We're seeing younger patients being affected with this earlier and earlier. It's not only the fact that osteoarthritis is growing, it's the consequences from that. So we can see the amount of total knee replacements that are being performed annually from 1991 to 2010. You can see that number is growing. So that's a historical look at what's been happening with total knee replacement. Now, if we look forward, we can see the tremendous growth in total knee replacements and total hip replacements as we move forward to 2030. So you can see the volume of cases and the impact of osteoarthritis is growing significantly. And so what are the opportunities we have to intervene much earlier in the disease process? One of the challenges is the fact that cartilage has poor reparative potential. And the two biggest issues with cartilage are the fact that it's avascular and aneural. Avascular meaning it doesn't have very good blood supply, so the reparative potential for cartilage is pretty low. And it's aneural, so we don't really know what's going on until it's too late. It's good in the sense that if there were nerve endings in cartilage, we'd probably be yelling in pain every time we took a step. It's bad in the sense that we don't know that cartilage is being damaged until it's pretty much too late. And if you talk to most total joint surgeons, oftentimes a typical arthritis patient that they see has pretty advanced arthritis by the time they come to our offices. And that's because we really don't know what's going on until it's too late, and that subchondral bone below the cartilage starts becoming impacted. So what's one of the biggest constituents of articular cartilage? Well, glycosaminoglycans is a big part of them, and hyaluronic acid is a big part of that. One of the interesting things around hyaluronic acid, it's one of the few molecules that's completely preserved across all species. So whether you're a bacteria, you're a rooster, or a human, we can move it between species without any issues, so long as we purify it. Now, one of the other challenges with hyaluronic acid is as long as it's not modified, the body sees it as normal. So if the body sees it as normal, we can shift it around. But how do we get hyaluronic acid to stick around in the joint longer? Well, we have to modify it. We have to do something to it. And Dr. Burt in the next section is going to talk a little bit about this. But if we modify the hyaluronic acid, we can get it to stay in the joint longer and potentially have longer effect. So osteoarthritis is not a simply wear and tear issue. You may have heard for so many years that it's just wear and tear of the joint. There's a lot of biology. There's a lot of things going on. So it's not just simply the rubber on the tire wearing out. You can see that it's a tremendous process. It's very complex, a lot of cell signaling and a lot of really biomechanical and biochemical issues going on. And here's another depiction of the complex nature of osteoarthritis. And so there's a lot of opportunities to intervene with new innovations and new opportunities. And this is where hyaluronic acid has a potential role to play as well. So like I said, hyaluronic acid impacts osteoarthritis by influencing or changing some of the molecular factors in the knee. One of the big ones is being things called inflammatory cytokines, IL-1, IL-6, and TNF-alpha. And when it comes to those inflammatory cytokines, what's really the challenge is what they do downstream. They increase these things called matrix metalloproteinases. So these are the things that break down cartilage. So if we can influence inflammation, we can potentially impact how cartilage breaks down. So this is just a cartoon depiction of what osteoarthritis looks like. And the typical example I give to my patients is, a lot of times patients don't really realize or think they know what osteoarthritis is. And I'm frequently surprised when I talk about osteoarthritis, I don't explain what it is, what the patients thought it was versus what it actually is. So the analogy I give my patients is, think back to Thanksgiving. If you snap open the turkey joint, you see that smooth, white, shiny stuff on the end of the bone. That's cartilage. Now imagine if I took a fork and started scraping it away. That's arthritis. And so when I speak to patients and I meet them where the patients are, they're able to understand what's going on. We have more effective communication and understanding and awareness of the disease process. So on the left here, you can see a picture of a healthy knee. You can see that nice white articular cartilage on the top. You've got the femur. On the bottom, you've got the tibia. And in the middle there in the background, you can see the meniscus. If we look on the right, what do we see? That white shiny stuff is gone, and we're down to that pink subchondral bone. You can see the meniscus is pretty beat up. And then below that, typically you'll see the cartilage is worn out on the tibia as well. So how do we diagnose arthritis, and what are the pitfalls, or what are the key factors of figuring out if someone's got arthritis? And number two, how severe it is? Well, one of the big things that you should realize is simple x-rays can tell you a tremendous amount of information if you get the right x-rays. So one of the classic x-rays to really give us a great amount of information is the Rosenberg view, or the notch view, or the tunnel view, where we get the patient to flex their knee about 30 to 45 degrees, and then we take an AP knee x-ray, and we bring into profile that aspect of the femur where we would expect that arthritis to be. So my typical 4 views for someone that's coming in to see me for chronic knee pain is a standing lateral knee x-ray, a sunrise view or a merchant view, so we can assess what's going on between the patella and the trochlea. Now, if you think about it, when most patients come to the office of an orthopedic surgeon, where do they point when they complain of knee pain? Invariably, a lot of patients will put their hand on top of their kneecap and say it hurts here. They'll just kind of envelop the entire anterior aspect of the knee, maybe the medial side, maybe the lateral side, but they rarely will take one finger and point directly laterally or point directly medially. They'll kind of just have this gestalt that it hurts in the front of the knee. And so the merchant view, the sunrise view, gives us a lot of information about what's going on between the patella and the trochlea. The next two views are the AP standing view, and then, like I said, the Rosenberg view or the tunnel view or the notch view. And this is extremely important because I have a couple x-rays here that illustrate what the importance of some of the common things we get with x-rays. So one is making sure the patient is weight bearing or standing. So on the left side here, this is an x-ray, an AP knee x-ray of the patient that was sent to me on a disc. And you can see the patient's got a reasonable joint space between the medial compartment and the lateral compartment. But what I did was I had the patient repeat those x-rays standing, because the x-ray that came on the CD, I asked the patient if they were standing up or laying down. They said they were laying down. So I took that same exact patient, I had them stand, and look what happens. That entire medial compartment collapses. So you have this artificial distraction when the patient is laying supine. So it's really important to get x-rays in a position of function or standing. Now, on the right side here, this was an eye-opener for me when I first came into practice and when I was in training. On the left side there, that's a standing AP knee x-ray. And when I had the patient flex about 45 degrees and took the same exact x-ray, what do we see? The patient is bone on the medial compartment. So same exact patient, same everything. And you can see there's a tremendous difference between the AP x-ray and the tunnel view or the notch view. So again, it's very important to bring into profile that area of the knee where we'd expect that arthritis to be. And I suspect in a lot of the research and a lot of the old literature, a lot of patients were included in what we thought was mild to moderate knee OA, when in fact they may have had more severe KL4 x-rays. So next time you're on United or Southwest or on one of the airplanes, and you see in the back of the airplane magazine that someone magically regrew cartilage using a laser or some kind of technology, now you know what was going on. They simply had the patient stand up and lay down, took the same exact x-ray, and you can see that the cartilage magically regrew. So this is a picture from one of my total knee replacements. Again, here's an AP x-ray of the knee. It looks like the patient's got reasonable joint space between the medial and lateral compartments. But when we get in there, look at where the arthritis was. It was on the posterior condyle. So this is the area of the femur that we're bringing into profile when we get the tunnel view or the notch view. So how do we treat knee osteoarthritis? So you can see the paradigm here that most of us have functioned in over time. Mild to moderate knee OA are exercise, physical therapy, simple analgesics. As we get to moderate OA, you can see things get a little more complicated, and obviously we have surgery. What you'll see in more and more of the research, the more recent research, is hyaluronic acid is really being targeted for patients with mild to moderate knee OA. We're starting to find that patients with bone-on-bone knee OA HA injections don't necessarily perform as well as we would hope, as we would expect. And a lot of the newer research really focuses in on patients with KL1, 2s, and 3s, not necessarily KL4s. And the challenge with this paradigm and with the guidelines, which you'll hear about in a little bit, is most of the patients come to my practice after they've failed simple analgesics and low-dose NSAIDs. So a lot of times patients have tried physical therapy, they've tried weight loss. I've tried weight loss. Everyone's tried weight loss. Isn't really that successful for a lot of people. And so a lot of times patients are coming to our offices with moderate to severe knee OA. And so what are the opportunities? What are the strategies that we can use to try to help those patients? So how do we figure out what treatment strategies work for knee osteoarthritis? There's so many options that are out there. And so how do we use research to figure this out? What we have to do is pretty much use concepts and strategies used by big data to try to make a sense of what the information is that's out there. So typically in a meta-analysis, would pool the results from two standard treatments and then pool those results and then compare those two. But if we want to compare multiple different options, we do something called a network meta-analysis. We try to drive and find correlations between different treatments based on the results of various randomized controlled trials. So this network meta-analysis looked at 137 randomized controlled trials, a little over 33,000 patients. And these were all the different permutations between the randomized controlled trials. So you can see placebo versus diclofenac, Tylenol versus diclofenac, diclofenac versus Celebrex, on and on and on and on. And so this is what it looks like graphically. And so you can see all the different comparisons that were out there. But what if we want to compare, for example, celecoxib to ibuprofen and naproxen to ibuprofen? There's no study to really compare the two. So what we have to do is figure out how Celebrex compares to oral placebo and how ibuprofen compares to oral placebo, and then find correlations and try to impute what's going on. So if we do that big data level of analysis, what do we find? Well, interestingly, what we find is Tylenol does worse than placebo. Of the pills, diclofenac does better than all the others. Generally speaking, injections do better than pills. And of all the injections, hyaluronic acid does better than steroids. So let's do a little deeper dive because it doesn't necessarily make sense that Tylenol is not as good as intra-articular placebo. I think we've all taken Tylenol. It works. I know it works. I think it's pretty common. So how is it that Tylenol doesn't work or is worse than placebo? So this was a picture of a knee arthroscopy that I did. On the right, you can see this is a supratellar pouch. You can see the red synovium angry synovitis there. I went and did the rest of the knee scope, and I came back to that same exact spot, and I took the picture again, and look what happened. All that red synovitis was gone. I didn't touch it. I didn't shave it. I didn't do anything. I just looked at that area. So what happened over those 10 to 15 minutes during the knee arthroscopy? We just flushed saline through the knee, right? So all of a sudden, that synovitis, that redness goes away. And so that's intra-articular placebo. So a lot of our randomized controlled trials were designed with intra-articular saline as a quote unquote placebo, but we can see that placebo actually does something, and it's actually better than Tylenol. So we now know that intra-articular saline or placebo is what we consider an active control. It's not a true placebo like a sugar pill, like we've traditionally been thought. So what happens if we take that knowledge and then relook at a lot of the research that's out there? What we find is there's a difference in what we find in hyaluronic acid and steroid injections and all the other treatments that are out there. And we find that actually when we account for placebo, we see a significant improvement in the outcomes in some of those classical studies. And those studies are what influence a lot of the guidelines that came down the pike. And so if we take into account the way research is designed, we start to understand the impact of how research impacts our clinical decision making. Thank you for your time.
Thank you, Dr. Dasser. That was excellent and really does set the stage. Dr. Burt, can I ask you to make a few comments or have any questions for Dr. Dasser?
Dr. Dasa, that was excellent. I did have some questions just out of curiosity more than anything else. Why do you think osteoarthritis is occurring in younger patients now?
So I think a couple of things. Obesity explains, I think about a certain percentage of it. Population growth explains a certain percentage of it. I think the other maybe angle of this is we're recognizing it early and earlier now. I think maybe 20, 30 years ago, you were just told to live with it. There were no real options for you. Surgery, knee replacement wasn't meant for a 50-year-old. So it could be that a lot of patients weren't simply coming in to see their physicians back then, and they were just living with it. And I think a lot of us don't really understand what the incidence and what the growth of the prevalence is. It just seems to be creeping up.
So I'm going to lead you into your algorithm in just a second in terms of treatment, but how do you reduce the inflammatory response beyond non-steroidals and steroid injections? Obviously, understand you can't flush out joints for every patient that comes in the door, right? So do you have an algorithm for injectables, and how do you look at the world that way with your injectable treatments?
Yeah, so I have an internal algorithm, and it's also, I think, based on age, and it's based on disease severity. So for example, if I have a 75-year-old with bone-on-bone arthritis, I'm gonna kind of lean to more aggressive surgical dialogue than I would, let's say, in someone who's 48 years old and mild to moderate knee OA. So I think those are the two main variables that drive my decision making and kind of what pathway I follow. So if I take the younger patient with mild to moderate knee OA, I'll kind of start way, way, way upstream and do NSAIDs and all the typical stuff. But then HAs kind of become one of my frontline therapies, especially in younger patients with early arthritis. But as disease progresses and the patient ages, then I get really to I cut to the chase essentially, where let's say it's a 73-year-old with severe bone on bone. I think we'll do a steroid injection or Toradol injection or something like that. And then I'll start quickly talking about a total knee replacement, because I think delaying surgery in someone who's eventually going to need a knee replacement, having that done at 78 instead of 75, I think patients somewhat are digging themselves a hole.
So there's some data out there from Tom Skulko at HSS, and there's been a recent study published in the Academy showing that if you inject steroids and or HA, you should wait 12 weeks before you proceed with a total knee replacement. Do you use that in terms of your practice parameters as well?
Yeah, I agree with that. And these are big data papers, so you need a huge number of patients to kind of find that signal. But I think for the most part, I've heard some surgeons, they wait 30 days, others will wait 90 days, but I don't think there's anyone that's not at least waiting some period of time
Right.
after an injection before surgery. So that's something you
Yeah.
got to think about.
Yeah, that 30-day study was presented at the Academy this past year. You didn't talk about the difference between avian and non-avian HAs. Could you talk a little bit about that and how you look at the world with respect to which one you would use?
Yeah, so what we're seeing, especially with the newer products, is a shift from rooster combs and avian-derived HA products, kind of the older generation, if you will, to the newer generation of HA products that are bacterially derived. And so you don't necessarily have a lot of the contamination and a lot of removing of the harmful proteins and things like that with the bacterially derived. It's a much more stringent process. It's a much more reproducible and process that you can replicate. So I think for me, bacterially derived HA products to me seem a lot more stable. They seem a lot more reproducible. I can trust them a little bit more versus the avian derived. I think there's a lot more heterogeneity with that.
Yeah, I think that's a great point. Do you have any problems in your state with getting insurance approval for the various HAs?
Are we allowed to name insurance companies, or will they go unnamed? Yes, I think a lot of us have challenges with insurance companies on a whole host of issues, HAs being one of them. Some insurance companies, you have to fail various treatments like steroid injections, which is a little counterintuitive,
Yeah.
depending on a lot of the data that's coming out around steroids and what they can do, especially the short-acting steroids and the potential harm that they've got, where you have to fail something that's harmful before you can move on to something that's a little safer. And then the others are just no HAs, period. They're not covered, and if the patient wants it, they have to pay cash. So it's frustrating, I think, for the patient.
37 states are still that way, sadly enough. One final question for you. I've been doing this for over 40 years, and I'm curious to see what your thoughts are. Do you use steroid injections in younger patients for any reason?
No, I've really backed off on short-acting steroids. I rarely use them now, especially like you said, in younger patients with good-looking cartilage. I really shy away from using short-acting steroids.
Okay. And do you use the long-acting steroids in older patients?
I do. So I'm definitely using long-acting steroids much more frequently now compared to short-acting.
Got it. Thank you very much.
Great. Thank you both. Our next speaker is Dr. Jack Burt, who will talk specifically to hyaluronic acid.
Thank you very much, Dr. Dasa. That was an excellent introduction in this topic. I'm going to talk about hyaluronic acid, the science, controversy, and current role. I've been involved with this whole subject with the Academy since 2013. I'll try to shed a little light on that as we go along here. So my disclosures are in the Academy on the Academy website. So what happened in 2008 when John Richmond was chairing the CPG? It was basically not an issue until 2013 when the Academy CPG guideline group took a very small sample of articles, basically about 8 out of 1,100. And they made the determination using MCII and MCID, which Felix Angst, by the way, was the one who first wrote about that. And I had the opportunity to meet him and send him a letter along with Ravi Bonaru, which Dr. Dasa did talk a little bit about. And we found out that, quite honestly, that this particular CPG was not appropriately looked at, and the conclusions were not appropriate. And this was written by Ravi and Dr. Lou McIntyre and published in 2015, questioning the methodology of the CPG. And so it's been worked on for the past 3 years, and there's been a significant change in it. But back then, there was no usage of hyaluronic acid. Non-steroidal drugs were okay, no acupuncture, no arthroscopic debridement. And then Tom Vangsness, who was at USC, then published this article in the Journal of Bone and Joint Surgery, talking about the influence of the CPG guideline, and major insurance companies, 37 states, basically ding the usage of hyaluronic acid, 64 million people lost private insurance coverage for Visco. And it was really interesting because then Medicare looked at it and approved it for usage, which I found rather bizarre. But if you look at in 2021, the guideline that was published is that hyaluronic acid intra-articular injection is not recommended for first-line treatment. And so the bottom line is what they're saying is you got to try something first before hyaluronic acid, and then it's okay to utilize. However, the insurers are really not following through on this because they've been able, they think in their minds, to save a good deal of money. I'm going to talk a little bit about the falsity of that. So why should a surgeon use viscosupplementation to treat patients with knee osteoarthritis? Well, we talked a little bit about this with Dr. Dasa in terms of the age of onset. And when and since I've been in practice for 40 years, early on, basically all we talked about is patients in their 70s and treating them, quite frankly, with steroid injections going right to a total knee. But now that we've been doing a ton of ACLs, a ton of meniscectomies, and there's a lot of literature that shows even 10 to 15% of meniscus removal will cause osteoarthritis to develop in 10 to 15 years. Frank Noyes has a wonderful 20-year follow-up regarding that. We now see that there's this time frame when we really have to do something for these patients with early OA and mild to moderate chondromalacia. And as Dr. Dasa pointed out, there's this algorithm that we all utilize: poor patient compliance with weight control. Acetaminophen, if you take 4,000 milligrams, can cause hepatotoxicity. Then you get into the GI complications, 17 to 19% with non-steroidals. So then you go to the upper left-hand portion of this slide, and you look at topical non-steroidals, intra-articular steroids, which we talked about already a little bit, viscosupplements, PRP, and stem cells, which truly are still illegal in this country. And then you're left with total knee replacement as the final straw, if you will. The trouble with total knee replacement, as has been implied earlier, is not everybody does well with this, especially in young patients. This is by Jarvid Parvizi from Rothman. 66% of patients feel normal. Stiffness is still prevalent in up to 41% of patients. And when you look at the literature, about 11 to 20% of total knee arthroplasty patients are dissatisfied after surgery. So it's not a perfect operation. Here's 14 articles recently published. So what is hyaluronic acid? Well, it's the endogenous hyaluronan that is the major hydrodynamic component of joint synovial fluid. It's produced by the synovial sites. It has a molecular weight of roughly 6 million Daltons in a young individual. It's derived from chicken combs. There are 3 injectable HAs in the US that have cross-linked hyalan. And you see all of these that are approved in the United States. And if you go outside the US, and I've had the opportunity to travel talking about this subject, there's up to 50 in some different countries, for example, India, and also, for example, some of the Asian countries. And I swear some of these are made in somebody's garage because there really isn't much oversight when these are prepared. One of the best articles on the product differences in intra-articular hyaluronic acids is Roy Altman from USC. And he looked at 68 randomized studies, published this in 2016, 26-week minimum follow-up, and found that high molecular weight greater than 3 million Daltons had greater efficacy than those with low molecular weight in all studies that were published. This was also true in the hip, by the way, and this was published in 2021 in the Cartilage Journal. And high molecular weight visco had greater efficacy than low molecular weight visco for up to 6 months after treatment. If you look at this particular chart, you can see here, or this table, I should say, healthy young synovial fluid is about 6 million Daltons, osteoarthritic synovial fluid is 1.9. And you can see Synvisc 1, Gel 1, and Durolane are truly about the only 3 that have high molecular weights. Now, why is high molecular weight visco important? Because it increases residence time, which is the amount of time the material stays in the joint so that the hyaluronic acid has more time in the joint to exert its positive effects. Prolonged residence time enhances chondrocyte metabolism, decreases the rate of chondrocyte apoptosis, which is death, stimulates the synthesis of endogenous HA, decreases shear, and it increases, as Dr. Dasa pointed out, the inhibition of matrix metal proteinases, which break down cartilage. Cross-linking increases the half-life up to 8.8 days, which can increase residence time up to 26 weeks. Durolane is closer to 4 weeks with respect to that half-life. And without cross-linking, the half-life of visco compounds can be as short as 3 to 20 hours. So if you're using a low molecular weight visco, it can be out of the body within 24 hours. So is there any evidence regarding high molecular weight hyaluronic acid preparations on the delay in total knee arthroplasty? Well, there is. David Waddell from Baton Rouge published this several years ago, 7-year follow-ups, 863 knees, 75% were delayed for greater than 7 years. Ong, about 14.8 months, and Altman, in 182,000 OA knees, had about 3.6 years delay. This is a wonderful article by Nichols, which shows that the more high molecular weight hyaluronic acid you give, and this is 50,000 patients, the greater the chance that you're going to prolong total knee arthroplasty. For example, one HA course was 28% had their total knee within 3 years, whereas if you give greater than 5 every 6 months, only 5% had a total knee within 3 years. So clearly repeated HA may delay the need for total knee. And here's a study by Wang, which I think is really important. What he did is he looked at 78 patients. This is a level 1 study, did MRI follow-up measuring tibial cartilage volume. And they looked at this group at 2-year follow-ups, which ones had increased cartilage preservation compared to the group that did not get it. The group that got it had increased cartilage preservation. The group that didn't did not. And you see this rapid fall off in tibial cartilage restoration. What does it increase type 2 proteoglycan in the hyaline cartilage cell? Well, the answer is, this is John Kelly's study out of University of Pennsylvania, a very tiny study, but using T1 row imaging, and he's repeating this as we speak, by the way, there was an increase in proteoglycan as evidenced by T1 row changes between 7 and 10%. Is it useful in the post-arthroscopy patient? I was involved in 2 of these studies, publishing them. And what we did is we looked at the meta-analyses showing improvement in symptoms in the majority of articles in the literature with decreased pain, pain upon motion, crepitus at 3 and 6 month follow-up. So for me, this is very common to utilize after arthroscopy in younger patients. And here's 7 articles written in the past 8 years, including the recommendation from Medicare, 65,000 patients, 2 Cochrane meta-analyses, found absolutely no correlation with MCII and MCID to refute the usage of high molecular weight visco. And in fact, it was just the opposite. The effect size was increased in patients who were treated with high molecular weight visco using the subjective evaluation. In patient perceptions, they all concluded, Dr. Dawson pointed this out, that of all the conservative approaches, visco was the highest rated treatment. This is a study in the JBJS that was recently published by Joe Hall. High molecular weight and cross-link formulations are a safe option in patients with knee osteoarthritis. They went on to say in 2016 that a careful exam of the most recently published articles suggests that visco is a safe option with a clinically important reduction in pain for younger patients with knee osteoarthritis in those formulations with high molecular weights or hyaluronic acid cross-linking. And that's very critical to understand. What about patient perceptions? There is this one study, 2,000 patients, 5 European countries, published in 2015. And if you look at this, the patients that were more satisfied, they had all the modalities on the left side, including narcotics, very satisfied. Visco was the greatest and most highly rated treatment modality. And also in terms of effectiveness, the patient now is making this comment that 74% felt that it was very effective. So what about a meta-analysis of intra-articular injectables? This was published in Cartilage just 2 years ago. High molecular weight cross-link visco is effective in the treatment of mild to moderate knee OA. What about effective on opioid usage? I think this is very important. There's 3 studies, Lou McIntyre, Chitnis, and Kangalov. They all found a significant reduction in the average number of days on opioids for patients who used hyaluronic acid that were being treated for OA. And as you guys know, when you see, when patients get referred from family docs, a lot are being treated with opioids. Here's one with almost 14,000 patients. Again, high molecular weight visco was effective in providing a decrease in corticosteroid injections and opioids and an increase in prescription pain medicine free days. So this was interesting. PRP plus HA is better than PRP or HA alone. 2 recently published studies in the Journal of Arthroscopy. And here's a 9-year follow-up of high molecular weight hyaluronic acid in the Journal of Arthritis Research, published in 2018. The relief of knee pain improved joint function when used in the following subset of patients. Again, decreased age, increased pain at time of injection, even increased BMI, increased joint space widening, indicating increased cartilage volume. So biochemically, I think something has to be happening at that cartilage level for these patients to be getting better. I want to finish with the economics of care because I think this is important. There's something called quality adjusted life years. Acronym is quality. It may be as high as 12,800 per year with avoidance of surgery. And another study showed $38,000 saved with incremental cost effectiveness ratio, which is the time prior to surgical intervention. So it not only helps us economically, but helps the patient as well. Here's a study published in 2020, 260,000 patients. And the conclusion were the patients in the HA cohort had decreased total medical care costs, decreased adverse outcomes, decreased use of, and decreased opioid costs. So I think all of this adds up to the fact that it's a very helpful modality for us to utilize in the treatment of OA patients. So I'm going to finish with just a few conclusion slides. High molecular weight cross-linked visco is useful for the treatment of patients with grade 1 to 3 changes of OA, and even in patients with grade 4 changes with total joint space collapse. It can postpone total knee by an average in literature of 3.8 years, but is increased with repeat injections. High molecular weight cross-linked visco decreases pain, opioid usage, and increases function. Cross-linking of avian-derived visco increases residence time and improves symptoms up to 26 weeks. The effect size of high molecular weight cross-linked visco resulted in a 38% improvement in pain relief in the FDA-sponsored studies when the Medicare did their work. It appears helpful after arthroscopy of the knee when early OA is noted at the time of surgery. It appears to decrease existing OA progression after injection at 2-year follow-ups. This is the Wang study. It may increase proteoglycan content utilizing T1 row imaging of hyaline cartilage after injection. And economically, without question, it reduces the cost per year of OA treatment significantly by avoiding total knee arthroplasty. Thank you very much.
Thank you, Dr. Burt. That really was excellent. Dr. Dasser, can I ask you to make a few comments now, and maybe you have some questions for Dr. Burt?
Yeah, thanks, Peter. It's a great talk, Dr. Burt. I think for someone that's been in practice and kind of been around the block like you have, there's a lot of wisdom I think you can give a lot of us that may be new to HAs or just learning about it. So when you talk to your patients about using HAs, how do you describe it? I mean, we typically say gel injections, but I mean, you just covered a huge amount of research here. How do you distill that down for your patients so it's understandable?
Yeah, well, I think that's a great question. And our discussion earlier, I think, helps a little bit. I'm like you. I do not use steroids unless it's an older patient. I can't figure out the logic in that. What I tell patients is that, especially after an arthroscopy where I see grade 2, grade 3 convolution, they've had an ACL or meniscectomy, or you're going in on a new patient that has a torn meniscus and has some grade 2 convolution. I'll be frank with you. I don't know what to do with those patients. And if you think about the fact that you're operating patients between the ages of 20 and 60, the majority of them, unless you're just doing total joints all day, you're going to see that all the time. So what I tell patients is, based upon a couple of studies in the literature, there seems to be evidence that there's some biochemical effect of these drugs on the existing cartilage surface, as long as you've got cartilage in your joint, that is. And so what I tell them, and I've been doing this for 15, 17 years, I say, I want you back every 6 months. I'm going to inject you with a hyaluronic acid, and I'm going to keep my fingers crossed that I'm not putting metal and plastic in your knee in the next 10 to 15 years. And if you explain it to them in that way, then they seem to buy into it, as opposed to saying, well, I've got this, this Jiffy Lube that I'm going to put in your knee that's going to give you some cushion. But the truth of the matter is, based upon some of the literature that I've reviewed, it appears that there is some biochemical effect that will hopefully keep you from having to have a knee replacement. And I think if you do that, you're going to do a better job at selling the patient of utilizing this despite the pain of going through an injection. And just for some of the younger guys in the audience, there's been 5 articles written on the best way to inject a knee. And I just think it's important just to mention that. Doug Jackson, who was past president of ANA, past president of the Academy, in 2002, believe it or not, wrote an article on what is the best way to inject a knee. And so what he did was he injected patients in flex postures, in full extension, medially, laterally, every which way you can imagine, and then used fluoro to make the decision as to whether the needle was in the joint. And he found that putting the knee in full extension, mid-pole of the patella, or even a little bit superior and inferior, is the best way from a lateral approach to inject the knee. Subsequent to that time, there's been 4 other articles using ultrasound and image intensification showing that that is the best technology or the best way to inject the knee. Now, I've had arguments with Brian Cole about this for years because he has everybody in his group flexing with the knee bent. But what I did one year is when I was teaching a course down at the Orthopedic Learning Center, I took the fellows and the residents and I stuck a scope in the knee. I said, okay, inject the knee with the knee flexed. And virtually almost every one of them penetrated the meniscus or bounced off the articular cartilage. And then I had them do it with the knee in extension. And not one of them skewered either any part of the knee that was at all important. So I think that is a good point to make, that if you're going to inject the knee, inject it laterally. I use a 26 gauge needle. I freeze it with some spray. Use a 26 gauge needle, put a couple cc's of lidocaine, make a wheel, and then I put my 18 gauge needle in, and patients don't even move. So I just wanted to bring that up because I thought it might be important for some of the people in the audience to hear that.
No, those are great tips, tricks. I think, everyone's got every which way of doing this, and I've heard so many different ways of doing it. So it's great to hear how you do it. So I just want to give you one patient. This is kind of the one that drives us all nuts. I've got a 5-year-old KL3, BMI 52,
Jeez.
and they're not going anywhere. So
right.
What do you do with that person?
Yeah, that's a great question. I'll use believe it or not, I use an 18 gauge spinal needle to inject them. And then I'll take a much smaller spinal needle. I have some at the office to really penetrate the lateral aspect of their knee to try to numb it up, because they're never happy with the injection because they're so huge. And some guys in my group before would use ultrasound for those particular cases, but I don't think you have a hell of a lot of choice in that patient. I will use visco and keep my fingers crossed that they get a second opinion.
I like that.
Honestly, though, what's really interesting about hyaluronic acid is that I've got some older patients who are bone on bone that come to see me every 6 months. They're in their 80s. They've got such severe comorbidities that you can't even consider putting a knife to them. And I inject them with hyaluronic acid, and they are super happy. And for the life of me, I can't figure out why they like it. But if I use a high molecular weight, they seem to get 4 to 5 months of relief. Then they come in every 6 months, give me a kiss on the cheek because they're just wobbling out, right, with their walker or cane. And they do well. And I've never been able to understand that. I've used long-acting steroids, short-acting steroids. They don't get any relief, and I inject them with high molecular weight visco. So I think it's worthwhile doing if you failed the steroid approach in those older patients that have too many comorbidities to consider doing a knee replacement.
Yeah, I agree. I agree completely. So Dr. Burt, you've been in practice for a long time, and HAs have been around for a while. You've seen the evolution and innovations in this space. How has your utilization of these products evolved over time?
Oh, that's a great question. So, when you think about the fact that really Synvisc was the very first one, right? And so I started using that over 15, 16 years ago. And the problem with that particular drug is that it has about 7.1 micrograms per milliliter protein. And the problem with injecting protein in the joint, it can cause a huge synovitic reaction. So I've had 4 cases of what's called pseudosepsis, which is where the knee blows up within 3 to 6 hours. I actually had one professional athlete come from several hours away, and he calls me and says, "Hey man, I got a problem." And he ends up in the emergency room. And then what always happens is those patients get aspirated. You send this murky, ugly looking cloudy fluid to the lab, thinking it's an infection, and they get admitted overnight, put on intravenous antibiotics. And in essence, what it is, it's this pseudoseptic response. And it can be a real problem. So I started adding steroid to when the only Visco I could use based upon insurance approval was Synvisc. And so there are 2 studies published now with large numbers that show that if you add a cc of steroid, and then David Waddell did a study down Baton Rouge, just shows if you add more than that, it actually degrades the hyaluronic acid. But if you add a cc of steroid, it reduces that pseudoseptic rate to 0. So I try to stay away from the drugs that can cause the pseudosepsis, to answer your question. And you are clearly aware of what those are.
What do you think? How do you think Durolane fits in kind of the grand scheme of things? I think it's one of the kind of more modern HA injections that have hit the market. How does that molecular structure and how does that product seem to fit compared to kind of the older ones?
Yeah, that's another very good question. Well, it has basically an unlimited, an infinite molecular weight, right? So the truth of the matter is it's probably the highest molecular weight out there. It has a really long duration and it's a minimum 4 weeks half-life. So based upon what I've read, so it's a great drug.
Great, thank you.
Thanks so much, Dr. Burt and Dr. Dasa. So a reminder to our attendees, please use the Q&A tab at the bottom of your screen to submit your questions. I already see them coming through, so I appreciate those who have sent some through. Please keep them coming. So Dr. Burt and Dr. Dasa, a couple questions here that have come through. First, Dr. Kenyon says, thank you for your time, great presentation. 2 questions. My first question is regarding use of local anesthetic prior to IAHA injection. Is there any evidence of potential negative effects of a local anesthetic such as ropivacaine or lidocaine given prior to injection of HA? My second question is time frame between IA steroid and HA. Is there a specific amount of time that you would wait after an IA steroid prior to administering IAHA?
So I guess I can start and tackle that. So local for the incision, so just for the skin, not a big deal. But if you want to use local in the knee, we know that there's a lot of data that shows that there's a significant amount of chondrotoxicity with the analgesics that we use. So lidocaine, ropivacaine, bupivacaine, you name it. There are a couple basic science studies where they take cartilage from either an animal or actually human. They grow it in the lab, then they expose it to lidocaine, for example, or bupivacaine, and they look to see how many of the cartilage cells are alive after a day with only 15 minutes of exposure. And there's almost 80% cell death. So injecting the local in the joint itself, has consequences to it. If you do it one time, is the big deal? Who knows? But just at the basic science level, that's what we know. Jack, anything else?
Yeah, no, I don't understand the logic of why you'd want to inject the joint with the steroid prior to the Visco. I think, as I tried to point out, I use it locally on the skin and down to the retinaculum so that my needle isn't penetrating an area which is not anesthetized. But I've never injected it prior to injecting a Visco. I guess I don't know why I would do that.
Yeah, I'm guessing that's probably maybe they're trying to reduce the pain of the injection somehow, or I'm not sure. That'd be my guess.
Yeah, but you're right about this. The studies you've quoted, and Connie Chu has some wonderful data on that, by the way. There are some studies showing that certain cane drugs are better than others with their effect on the articular cartilage. But I totally agree with what Dr. Dasa said.
Great, thank you. Another question here. Which are the high molecular weight HAs?
Well, in the U.S., basically, it's Synvisc, it's Gel 1, and Durolane. If you look online and Google all the different HAs, those with molecular weights of 1.2 million Daltons will be advertised as high molecular weight HAs. And the reason is it's a marketing tool, and the groups that are not one of those three that I mentioned don't want to be left out of the discussion, right? But I think as Roy Altman pointed out with his study in AJSM, they just simply don't function as well as those with a molecular weight over 3,000 Daltons. 3 million Daltons, pardon me.
Wonderful, thank you. Hold on, just pulling up the next one here. From Dr. King. Hi all, late to the meeting, but wondering if you have used PRP instead of HA. If so, what is the visible/measurable difference between the two treatments?
Go ahead, Jack. You probably have a lot longer experience with that.
Yeah, so I do use PRP quite a bit, and I use HA first because PRP is a cash basis only. In Minnesota, the variability between PRP charges is anywhere between $600 to $1,300. And so I don't charge nearly as much as most of the other people do. So I get people coming around from 5 states to do it as a result. But to answer this question specifically, I'll use HA first, high molecular weight, because it's covered in our state. It's a patient on Medicare, they're covered. And I am seeing maybe a little bit better result with PRP, maybe by 2 to 5%. And the literature is pretty clear on that. There's a great study out of Rush which compares them, and that's what their findings were. Maybe 68 to 72% in terms of success rates. I'm intrigued by the PRP plus HA studies that have been published though, because I am finding that when I use a high molecular weight hyaluronic acid plus PRP at the same setting, I'm getting a solid 6 to 8 months of for patients with Kellgren 2 and even some Kellgren 3s noticing improvement. So they'll come in repetitively to get both.
It's interesting. There's actually a study published today on the combo for hip arthritis. I think it was in journal JOS or one of the other journals showing with combination better results than individual treatments. So that may be something coming down the pike. But in the context of PRP, the other thing to think about is the ability to isolate the platelets, older patients, younger patients, the health, the type of system you're using. There's a lot of variables you have to think about when considering PRP and how effective they are. The biggest challenge for me is that it's cash pay. So most of the patients, want something that's covered by insurance. So and the variability, as Jack mentioned, is pretty high. They've also got a lot of people using BMAC or stem cell treatments, and that can be as high as $3,000 to $5,000 for an injection, and that's off the table for a lot of my patients. So until PRP, at least in my practice, gets covered by insurance, I don't have a ton of patients really asking for it, especially in the older fixed income Medicare type group.
Sure.
This may have been answered, but another is when you inject HA with PRP, is this done at the same time or in a series?
No, at the same time. And for those of you who still have patients who only can use Synvisc, I add a cc of usually Celestone. And there's some data that shows that may be a little safer on the joint surface within the same syringe. And then I inject it simultaneously. One of the other questions that always comes up is if you do an arthroscopy and you see grade 2 chondromalacia or grade 3 chondromalacia, say in a 35 or 45-year-old, when do you inject the HA? And the answer to that is, I don't think it makes any sense to do it at the time of surgery because it tends to leak out. Number one. Number two, from a coding perspective, you should wait 3 to 4 weeks and code it as osteoarthritis because that's what you're seeing. It's the only way you're going to get reimbursed. So I always wait 3 to 4 weeks after the surgical intervention. I don't code it as a follow-up. I code it as an osteoarthritic patient. And that's total. We teach this, by the way, at the arthroscopy meeting. So I don't think I'm stepping out of place saying that. And then that's the time that I do it. And I'll simply tell them, and I show them their pictures and I say, look, this is what your femoral condyle looks like. It's all chewed up. You got some grade 2, grade 3 convolution. I think you should do this. And I'd like to see you back every 6 months if you're willing. And that's why it's critical, by the way, to make sure that you make that injection as painless as possible, because it's really hard to get a patient to come back every 6 months. And you have your PA stick an 18 gauge needle in, and you hear them screaming down the hall. Trust me, you won't get them back at 6 months to try to do them every 6 months. So that's why the spray, local anesthetic with a diabetic needle, and doing a nice gentle injection from a lateral approach, in my opinion, makes a huge difference in getting those patients to come back on a regular basis.
Yeah, and I do exactly the same thing. I'll see them back at 2 weeks. I'll show them the arthroscopy photos. We'll go over what we found. And I tell them, if you have any residual stiffness, soreness, what have you, now that we took care of the meniscus or whatever the issue was, come back. And some patients will come back at 4, 6 weeks, 8 weeks, something like that, saying, I'm not 100%. I still have, the sharp pain or whatever the pain was from the original issue is gone, but I still have these residual kind of arthritic symptoms. Will kick in the HA injections at that point. So I think it's a great adjunct to arthroscopy, because if you think about it, the arthroscopy has eliminated all the other pathology. So what's left is really the arthritis.
Yeah,
so you've actually kind of cleaned house.
Yeah, no, that's a great point. And so I'm a little bit different than you in that respect, I guess. I don't wait for them to be symptomatic. I just tell them, I want to see you back at 4 weeks because this is what you got. And I think to try to preserve your joint as long as I can, I'm going to start injecting you on a regular basis. And this is why. And then I give them the spiel about developing increased.
You see every scope back for a 4-week injection, 6 weeks or somewhere.
If they have grade 2 countermalacia, grade 3,
okay.
Absolutely. Because I honestly don't know what else to do with these patients. Right. Because all you're doing with the anti-inflammatories and the analgesics is basically hiding the fact that they've got this grade 2, grade 3 chondromalacia, which is going to get worse with time, right? So is there anything else you can do for them? I suppose you could do PRP. I suppose eventually once true stem cells are approved, then we could do that every 6 months. But I don't know what to do in that 30 to 50 to 60-year-old patient to try to keep their joint intact prior to having to generate and do a total knee replacement.
I mean, that's a good point. I've never thought about not mandatory, but having that part of a routine automatically bring them back. I've simply said, if you're doing well, that's fine. If not, and you're still having some residual symptoms, we'll kick in the HA injection. So that's interesting.
Yeah.
Thank you both. We have another one coming in here. Do you combine HA and microfracture in a chondral lesion?
Oh, Jesus. All right. So please go back and look at an article I wrote in 2015, Journal Arthroscopy. Microfracture should never be done. And there's been multiple articles written about that.
Though.
Oh, Jesus. Yeah, you touched a red, you went over a red line with me there. Sorry. But there's a whole series. There's a great article for whoever asked that question by Erlander. You got to drill. You got to get past 4 millimeters because you're not getting past the calcified cartilage where the regenerative cells, the stem cells are. And so please get rid of microfracture in your practice. Drill it. It's the same code. Do not do microfracture. That's number one. Number two, yes, I will. I will then later do hyaluronic acid. But remember, with microfracture, with drilling, you're going to get fibrous tissue cartilage. So that's a whole different discussion, whether or not we should be doing cartilage plugs, and that's a whole different situation. But if you're going to drill an area or just debride it or do a superficial abrasion, and even superficial abrasions now, there's some research at 15-year follow-ups that show that actually works better than microfracture, study out of the Journal of Arthroscopy. Then yes, later on you can do the hyaluronic acid 4 weeks later.
Actually, we'll put a plug in. There's a new device that just got approved by the FDA about 2 or 3 months ago called CartiHeal. The only device off the shelf that actually regrows type 2 collagen or hyaline cartilage. So be on the lookout for that. It may supplant microfracture as one of the go-to treatments to delay arthritis. Or drilling, I'm sorry.
Thank you.
Yes, a disclaimer. He just wrote back. Sorry, I did mean drilling. So.
Oh, thank you. Thank you very much. Appreciate that.
Yeah. We've got a couple more minutes. If anybody else has questions, please put them in the Q&A. We've got about 1 minute left. I have one here. If you use an HA that recommends 3 to 5 weekly injections, are you using PRP with only one of the injections? With all weekly injections, using PR would be cost prohibitive. Also, as a family physician, placing my patient on long-term NSAIDs, or has frequently been done on every 3-month steroid intra-articular injection, leaves me with major issues related to poor control of diabetes, increased CAD issues, having to deal with CKD or GI bleeding issues.
I'll take that one very quickly, and then Dr. Dasa can respond. If you're doing 5 injections, you're using an extremely low molecular weight visco, and I'd quit doing it. That's number one. Number two, if you're going to use a steroid, there's 2 great studies published in JBJS that shows that you can get up to 26 weeks relief from it. I use it all the time when I failed hyaluronic acid in my patients with bone-on-bone disease that I'm not going to do it totally on.
Yeah, I agree. I agree with Jack. I think if you're going to do PRP in the context of HAs, you don't do it after each injection. You can do the HA injections and then follow on with PRP, after you do the series. I don't think any of us disagree with NSAIDs and their impact on systemic issues. They get used quite a bit. They're not meant theoretically for chronic long-term use. They're meant for short-term episodes, but yet obviously, they're over the counter too, so we can't necessarily control that. But we know it's an impact on hypertension, and we know the black box issues with that. So that's a challenge. As far as steroid injections and diabetes, that transient hyperglycemia is a big problem. Dr. Burt brought up Zilretta. There's data, and it's on the label that that you can eliminate or mitigate the hyperglycemia with long-acting extended release steroid injections.
Right.
So if your orthopedic surgeon that you work with doesn't know about it, that may be a great treatment to let them know about to reduce the systemic issues that you're seeing.
Well, Dr. Bird and Dr. Dasa, thank you so much for your time. This was a highly educational symposium and really appreciate it. And a special thank you to everyone who joined us tonight. And I hope you all have a great evening. Thanks so much.